we are here in honor of Occupational Therapy Month to celebrate and do a special webinar on some topics shared by one of our wonderful faculty members and very talented occupational therapist, Julia Wood. So you're just going to listen to me for a couple of minutes as I do a few introduction slides, and then we're going to turn it over to Julia for her lecture on going back to our roots, habit training in LSVT BIG. So on her next slide here, you're going to see Julia's bio. She can tell you a little more in detail about herself as she starts to talk, but she has worked for many years as an occupational therapist. She has been an instructor for LSVT Global also for many years, and in her new role actually works with the Lewy Body Dementia Association in a new role that is new and exciting and different. And so I'll let her tell you a little bit more about that when she comes on board. As far as disclosures go, there are just a few mandatory disclosures that all LSVT faculty have both financial and non-financial relationships with LSVT Global. Julia, you can advance. There you go. And Julia is a consultant for LSVT Global and receives lecture honorarium from us as well. A few logistics on the next slide is, again, we want your microphones muted from wherever you're joining us. You can ask questions at any time during the webinar, but we will hold those questions till the end. So there is the option to enter questions into the chat function, and we will take questions at the end as long as time allows. Also, there were handouts that went out in an email. I will also upload those into the chat function here after Julia starts talking, so that if anyone missed getting them by the email, you can open them from there. There will be a survey that will launch at the end. For those of you watching live, it will automatically launch. For those of you that might be watching an on-demand version, you will need to complete that survey to be able to get a certificate of attendance. So that is for both on-demand and for live viewing. On the next slide here, we'll talk just briefly about self-reported CEUs. So we do not register these webinars for CEUs, but you may use them for self-reporting. If you're going to do that, you're going to want to keep your certificate once it comes. It will take 1 to 2 weeks for it to arrive in your email box. And for on-demand, you must complete that survey link after the conclusion of the webinar in order to get that survey. The webinar is 1 hour long, and attendance for the full duration is required to get that certificate. CEU requirements differ by state, so not all states might accept self-reported CEUs, but I would definitely keep the handout, your certificate, and those things if you're trying to get CEUs for the presentation. With that, I'm kind of done with the business end of things, and I'd love to introduce to you Julia Wood. I'll let Julia tell you a little bit more about herself and take you through her slides today. Thanks, Julia.
Excellent. Thank you so much, Jenny. And welcome, everyone. Thank you for joining us for this special little celebration here of OT month, and a very near and dear topic to my heart, too. So I'm a little bit of a nerd in that I like both science and I like history. So we're going to be talking about habit training, which is a concept by Eleanor Clarke Slagle. So we'll get into that and how it relates to this current concept that you see so much in the literature for neurorehabilitation of task-oriented training. And also we're going to define the symptoms of Parkinson's disease and really look at how they impact function. And then we'll identify different assessment tools and research evidence that can be used to support goal-oriented, person-centered care for people with Parkinson's disease. And we're going to associate the many functional applications of the LSVT BIG protocol and really look at how they link up so nicely with our occupational therapy roots of habit training. All right, so a little bit more about me before we get started. As Jenny mentioned, I was in clinical practice for many years at Parkinson's Center for Excellence here at the University of Pennsylvania. And then during the pandemic, like so many, maybe even of you, I transitioned my work roles, and now I work for the Lewy Body Dementia Association. And so I'm the Director of Professional and Community Education. So if you're looking for more education about Lewy body and Parkinson's disease dementia, you can send me those questions as well. All right, let's go ahead and get started. So let's kind of think back to our OT roots a little bit, which are so much ingrained in the arts and crafts movement. And so Eleanor Clarke Slagle is considered by most to be the mother of occupational therapy. And she proposed this concept of habit training as a primary OT model of treatment. And we'll talk about what that is a little bit more. And so she believed that habit training focused on creating a structure that fostered a balance between work, rest, leisure, and it was based upon the philosophy that engagement in these meaningful routines really helps to shape a person's well-being. And so I think this is so much at just the heart of what we do as occupational therapists. And so you might remember in 1915, she opened the first OT training program, the Henry Favell School of Occupations at Hull House in Chicago. So just that little history refresher for you. And then I think that you can't even look at our domain and process without noticing that right dead in the center of that bullseye is, working to achieve health, well-being, and participation through engagement and occupation. And I think so much, unfortunately, this gets lost a lot now with demands for documentation, RVUs, a lot of things I think are really impacting people continuing to do this in their practice. So I'm going to make sure here that everybody's muted. Here we go. All right. So moving forward from that, so a little review here of task-oriented training and what it is. And so just a reminder here, this really is not linked just to Parkinson's, but so much in neurorehabilitation, especially in stroke literature, that we want to select activities and tools for that therapeutic engagement from the person's daily life. And in order to find out what that's going to be, we've got to collaborate with that client to really select what is meaningful to that individual, as well as what is functional. And then we also want to ultimately analyze, both the person and aspects of the environment in order to really understand their task performance. And then so much like motor learning and other concepts in neuro rehab too, we're going to structure that practice of the task and provide feedback so we can facilitate ultimately that motor learning. And then our goal is always to develop an optimal movement pattern that's going to help that person be most successful in their task performance. So I think that, I don't know how many of you saw that recently the Parkinson's Foundation came out with new numbers that the estimates now on Parkinson's disease are much higher than what we had originally thought. And so now I think there's up to 8 million people worldwide living with Parkinson's, and that is expected to double by the year 2040. And, there's a lot of information out there kind of asking questions about why this is happening. Is it just that the population's getting older? Is it teratogens in the environment? At the bottom, you see Dr. Ray Dorsey and Boston Bloom. They've written a book called Ending Parkinson's, and they've done some research looking at these different teratogens. And the Michael J. Fox Foundation has a referendum out. So I think there's a lot of movement in this space of really trying to understand these numbers. But as clinicians, I think we have to ask ourselves, are we ready for this surge? Because they're going to need our help. So let's talk here about the impact of Parkinson's on habits. And I'm not going to spend a lot of time on this because probably a lot of you are more familiar with these concepts. So when we look at the motor symptoms of Parkinson's, essentially those cardinal symptoms, are rigidity, so that stiffness, especially in the joints and the flexors, some tremor, often at rest, but it can be in action. And then that slow movement, that bradykinesia, and hypokinesia, or small movement. But there's a whole lot more. We know that we see these changes to their gait and functional mobility, where their step length is smaller, their arm swing, especially to the back, is reduced, their posture starts to be more hunched and tipped forward, and we see reduced speed with their movement, and then ultimately often festination with gait, where they become like a runaway train and it's hard for them to control their gait forward, and then often freezing of gait too, kind of the opposite, where they feel stuck and have a hard time stopping their movement or starting their movement. We also know with handwriting, we sometimes see these changes to really small handwriting called micrographia. And then the facial expression, even the movement of the muscles of the face changes. So they get this mask face or hypomemia. Vocal volume can change, loss of automatic movement. So things like leaning forward to stand up from a chair become more difficult. Decreased dexterity with the hands doing things like buttons, getting clothing on, getting a coin or a card out of a wallet. We see deficits in force generation, and this can often be misunderstood as weakness by the person with Parkinson's, where they feel that their hands are so weak or their legs have gotten so weak, but they're actually just not, it's a sensory motor issue where they're not sensing that force generation. We can see some dystonia, often in the neck or in the toes, where the muscles will do this involuntary cramping and stiffening. Dyskinesia is actually a side effect of the medication, and that's kind of that wiggly movement that you'll see sometimes. And postural instability, you'll note here, is often listed even as one of the cardinal symptoms, but it's important to note, I've put it here in red and with a star, you see a lot of postural instability early on in someone newly diagnosed, a lot of falls, a lot of severe balance impairments. You're probably looking at more likely an atypical Parkinsonian disorder like PSP, MSA, or CBD. So that's one that you really want to think, if you see a lot of that early on, you need to let their doctor know, alert them of the changes that you're seeing. This is really where OTs come in a lot, are these non-motor signs and symptoms. And so these are often more disabling or bothersome to people with Parkinson's, and they really interact and exacerbate the motor symptoms. So cognitive impairments can have a wide range, from mild cognitive impairment, even subjective cognitive impairment early on, where you might not find a deficit via a MoCA or a mini-mental, but they still notice changes to their executive function, multitasking, dual tasking. As the condition goes on, of course, we see more and more changes with executive function, visuospatial function, and possibly dementia. It's estimated the lower end of the estimate is around 50% of people with Parkinson's disease will develop dementia, but the more recent numbers that came out suggested possibly up to 80% of people will develop dementia if they live long enough with the condition. Psychiatric disturbances, such as changes to mood, like depression, anxiety, and apathy, are very common. And then also hallucinations and delusions can be a side effect of some of the medications, but they also can be a sign or symptom of Parkinson's as well. Autonomic features such as constipation, urinary changes, sexual dysfunction, orthostatic hypotension can be very problematic. And then we see a lot of sensory changes, like that reduction in sensory awareness. Some people have odd pain or tingling or kind of nerve sensations. And very common too are sleep disorders, where people may have trouble falling asleep, staying asleep, or feel restless when they're sleeping. And fatigue is the most often reported non-motor symptom, and it can be secondary to a sleep disorder, but it can even, people can get plenty of sleep and still feel very fatigued. And then lastly, this olfactory dysfunction, where people have a loss of sense of smell, is often one of the early non-motor symptoms of Parkinson's. So then when we look at how those motor skills really impact function, we know that the loss of that automatic movement really makes it hard for people to swing their arms when walking, to initiate certain movements. Their motor planning for things like getting in and out of a car, getting in and out of bed become very impaired. And we also see these changes to amplitude of movement, slower task performance, bradykinesia, loss of movement, small movement. So across the board, it's very unique to the individual, but there are a lot of movement changes. So then we know that rigidity and tremor, were part of those motor symptoms early on. So we'll see those changes to fine motor coordination, decreased dexterity, trouble with manipulation, but often with sustained tasks like keeping that consistent movement for whisking or stirring. Often difficulty with functional reach into the arm going into the sleeve of a jacket or reaching to get the seatbelt. Changes with fine motor task. Everything becomes slower. If you've treated anyone with Parkinson's, I'm sure that if you ask them what their number one concern is, a lot of times they tell you everything is slower, everything's taking me longer. And then also this decreased independence. And eventually over time, if we don't intervene and work on ways to really help them cope with all of these changes, what you typically see is occupational deprivation. So, we really want to make sure too, when we're considering all of those movement changes, when you're working with someone, that we're also thinking about their process skills. So they often have impaired problem solving. I remember one of my early clients that had 8 falls. When I asked him, well, what did you do different? Did you try anything, to see if you could reduce your falls? And he said, well, I bought bigger, he was putting on his pants when he fell. He's like, I bought bigger pants, but it didn't help. And so sometimes you'll see these changes where you're like, I don't think that person would probably normally try to solve a problem that way. Sometimes their mental flexibility is really off. They're not able to really think of a lot of different solutions to a problem. Difficulty multitasking is very, very common. You'll see impaired decision-making often, and difficulty starting and stopping and planning and organizing tasks as well. It's important to note that in this article cited here by Dan Weintraub in 2015, these are not later on that we see these. A lot of these issues right here happen even in early stages and at diagnosis for people with PD. I think that if there's one thing that we really learned over the pandemic too, is the impact of the social, engagement on everyone. As we saw people, not socializing during the pandemic, being isolated, we started to really see a lot of problems for people with progression of their disease. So, so many of these symptoms impact that on its own without a global pandemic. The facial masking makes it hard for other people to really read what they're thinking and maybe feeling. The vocal volume and speech changes make it very difficult for social interaction. Bradyphrenia can really impact verbal fluency and engagement in conversation. We see decreased gesturing, so they don't use their hands as much when they're talking. And then often too, with those changes to fine motor coordination, we'll see trouble with written and email communication. All right, so let's talk about some ways that we can assess and really, use evidence to support this concept of habit training. So we always want to use a client-centered top-down approach, as I'm sure you all do. We've got to get that occupational profile so that we can focus in on participation and occupational performance. We want to look at patterns and routines in their daily life, look at what their values and interests are, and identify what the areas of concern are for them in those daily activities. And then this is what really guides us into what outcome tool do we need that's going to really measure this change, going to really help guide that intervention. And then ultimately, I think it's always important when possible to collaborate with the client and their family to prioritize goals that are really meaningful. Now, early on, sometimes people don't want to come with their family to therapy, and that's okay. It's totally up to the individual. But I think a lot of times it really helps. It takes a village, and they need their home village as well. This is a quote that I really like when we think about collaborating with PT. So those of you out there that are certified in LSVT BIG, I really encourage you to, pair up with your PT cohorts. If you're not and you're thinking about it, I really think you want to look at how could we work together as a team here, because when we collaborate, PT and OT, and we focus on these different aspects of the assessment and the interventions, we look at how we can complement each other. And the more that you can be aware of the instructions, the cues, the stepwise approach, whatever the other is doing, it really, really helps strengthen the therapeutic process for that individual, because now they're getting those same concepts from both PT and from OT. It's like, I think it really reinforces it when they hear it coming from two people. So here's some assessments that you can think of that really look at activity and participation, and I think we'll work more toward that task-oriented or habit training model. Of course, the Canadian Occupational Performance Measure, I think most of us are familiar with. The PSFS, I liked a lot in my practice. It's free, where the COPM you do have to pay for. And sometimes I found that my clients with Parkinson's were a little confused by the COPM. They're like, well, how would I rate my satisfaction more than I would rate my performance? How would I be more satisfied than I'm able to perform? which is kind of a valid question, but so you might find that it's a little more simple sometimes to use the PSFS. The physical performance test has a lot of different, can be very client-centered activities depending on what their needs are, as well as the Parkinson's activity scale. It gets a little bit more into sit to stand and different transfers and mobility. The PASS, for a long time, the performance assessment of self-care skills. I thought you had to do the whole thing. Shows what I know. You can do different elements of it based on whatever tasks that you're trying to work on for that individual client. And you also can even make up your own domains within it and your own assessments if it's something very specific for that client. The Nottingham extended activities of daily living gets a little bit into functional mobility and different daily tasks. One of my favorite things in the entire world for really zeroing in and making it client specific is goal attainment scaling. And you'll see that in a couple of the research articles that I'm going to highlight tonight. And then the activity card sort is interesting because it's kind of like an interest inventory with pictures. You have all these different pictures of ADLs, IDLs, leisure tasks, and you really can get an idea of past, participation compared to current participation, and get some good data in there as far as tracking change over time. All right, so this was a nice systematic review if you're looking for something to kind of guide that concept of habit training here. And you'll notice that here they found that mobility, balance, and independence in everyday life activities were really improved statistically in the short and long term when people did combine treatments of OT, PT, and speech. We really want that team approach. And you'll notice here too that as far as specific interventions, cognitive enhancement and interventions for upper limbs resulted in improvements in attention and memory skills and in mobility. And we're going to talk a little bit more about what some of those things look like in a bit. All right, so this is one of my favorite studies in the entire world. This was a randomized controlled study of whether setting specific goals improves the effectiveness of therapy for people with Parkinson's disease. So they had 50 patients with a clinical diagnosis with PD, and these were all patients who acknowledged that they were having impairments in their manual mobility. And then they randomized them into two groups. And so in the experimental group, they had 25 people, and they were included in an intervention that was focused on different task components that involved goals that were proposed by the participants. The patients in the control group, on the other hand, received a standard intervention that focused on impairments that worked on range of motion, grasp, and manipulation. Both groups did sessions for 4 weeks, twice a week. The outcome measures, you'll notice here, the primary outcome measure was goal achievement using that goal attainment scale. The secondary outcomes were manual dexterity, evaluated with the Purdue pegboard test, hand grip strength, and also finger prehension force, just using a dynamometer. So I found that when they used the patient's selected goals, the intervention was then sequenced in order to manage that motor task. So maybe it was getting a shirt on, picking the shirt up from the wardrobe, putting it on, buttoning it. And then they worked on the specific components with that task analysis of each of these, working on reaching, bimanual function, manipulation, dexterity. And then they used a lot of things that we have to use in neuro rehab, visual cues to really increase attention, practicing with different types of clothes, like different shirts, pullovers, or coats. Depending on what that patient's need was, you wouldn't have someone put on a button-up shirt with a tie if that's not something they ever wear. So the results, after 4 weeks, they found that there was a significant between group improvement in the goal attainment in that experimental group. And when they compared that to the control group, the experimental group also showed a significant improvement in manual dexterity and finger prehension force. So not only was the goal working on something that was meaningful and relevant to them, they got these improvements in their goal, of course, but also they got those better improvements in their manual dexterity as well. So the clinical relevance here, I think that this is so important, and this is going to tie in later when we're talking about functional component tasks, hierarchy tasks, carryover assignments, that when we target therapy towards specific goals, that it leads to greater change. In this case, it was an arm function. So they found that people with Parkinson's disease showed greater improvement in their goal attainment if they're focused on that specific set of goals rather than just a standard approach of having people manipulate balls or pegs or putty. It really does need to be meaningful. Now let's look at this, because a lot of times we know with dementia, that leaves people out of a study. But this one, they wanted to look at this goal-oriented training for people with Parkinson's disease dementias. And so this was another randomized controlled trial. So they did this goal-oriented cognitive rehabilitation. And what that means is they did goal setting and they used evidence-based strategies to focus on improving that function in the everyday activity. So basically this task-oriented training, right? And they found that this was superior to treatment as usual, and they even had a relaxation therapy group in comparison. And they found that it was feasible and potentially effective for people with dementia, but we need more information. And another thing that came out of this study that was really interesting was as the people with Parkinson's who had the goals started to do more, guess what? All the care partner outcomes got better too, because it reduced their burden. They didn't have to do so much. So this is a case study that's really interesting where they looked at LSVT BIG on specifically occupational performance in a 73-year-old woman with Parkinson's disease. They used the COPM and the PASS to measure these changes over time. And they found that the client's perceptions of their occupational performance and their satisfaction on the COPM improved, and they improved their independence and adequacy on the PASS. So I think that this might just be a case study, but if you really dig in there and use LSVT BIG in that patient-centered way, you'll notice these improvements to occupational performance. Now, we are here talking mostly about Parkinson's disease. It is Parkinson's Awareness Month, but there was a study that looked at this in stroke, and they found improved confidence and engagement in these valued occupations using LSVT BIG. So you'll notice there in the quote that they feel it is a promising intervention to improve occupational performance. Once again, we need more research to clarify what elements of the program are essential to that. But I think for me, it's a no-brainer. I feel like when you look at the layout of the program, it all works together to really support those improvements in function. All right, so how does habit training, how are we using this in LSVT? This is where I'm going to start to kind of tie the history and the science together. So LSVT BIG is an intensive exercise-based therapy program. And when I first started a million years ago, it feels like now, people would say to me, well, that's just for physical therapists to do. It's an exercise program. It's a standardized therapy protocol, and there are exercises as we're going to look at, but there's a whole lot of function that's really salient and meaningful. It has a prescribed dosage and a method of delivery, so we're looking at a consistent frequency and duration and strength of dosage. It's practiced with high effort. We know for neuroplasticity, for motor learning, so important. It's always delivered by LSVT BIG certified OTs and/or PTs in collaboration with LSVT BIG certified CODAs and PTAs. So our target is really simple. It's hypokinesia and bradykinesia. We know that these symptoms are present at diagnosis. If you remember back to those motor symptoms I highlighted in the beginning, they correlate with that loss of dopamine in the brain from those brain cells dying off, especially in the substantia nigra where they produce dopamine. Also correlates with disease progression. So over time, that hypokinesia and bradykinesia is increasing. And it is generalized really across motor symptoms. So it's not just in the legs or arms or hands. It really is throughout the whole body. Even the gut gets slower. So the mode is intensive and high effort. We're trying to build these new habits, right? We have to make it essentially a lifelong habit of practice too. So the intensity is going to be across all of the sessions, and it's going to be the minimum dosage for efficacy. And that dosage is pretty high. It's 4 consecutive days a week for 4 weeks in a row. That's 16 sessions. And these are 60-minute sessions because there's no way you get through all of it in anything less. It is always meant to be individual therapy, not a group. We do have a group application called Big for Life, but that's a different subject for a different day. And there's always daily homework practice and daily carryover exercises all 30 days of the month. So if we're talking about habit training, we're going to definitely be practicing it enough to make it a new habit. And ultimately, our goal is calibration. We want our patients to learn to use these bigger movements automatically in their daily life so that they can see how these help them get out of the car more effectively or keep up with their friends when they're walking. We want them to be able to maintain this and work to maintain this over time. So this is one of our favorite gentlemen here at LSVT Global, Mr. Leon. And this is calibration from his perspective.
The fact about the bigness is I've learned that like when I put my pants on in the morning here and I put my feet in the jeans, I'm kind of a little bit groggy, you might say, and I start pulling and I start struggling, and then all at once it clicks on me. It says think big, and then wham, it changes, literally changes. It's like they showed put your jacket on, don't sneak it in there. You go wham, So the thing about the exercise is not just the particular exercise, it's the mentality of accomplishing things with big movements, because with the Parkinson's, it retards you in a sense. So you have to mentally shift to big, you really do. And I find, man, things work a lot better. There's things I'm doing now that my daughter says you shouldn't do it, and I go do it, because I think big, I carry things, that are a little heavier than what I would in the past. So it's really, it's just that bigness, and so I didn't quite understand it then, but I learned, what it meant as I went on.
So that's Leon's take on that big movement and what it's done for him. He's such a chatty fellow. We love him so much. So this is an example here of an LSVT big treatment session. For those of you that aren't certified or maybe haven't been teaching for a while, you'll notice on the left-hand side of the screen, you have these maximal daily exercises, and there's 7 of them. You're doing about 8 to 10 repetitions there. And they're in different stepping patterns. We've got some multi-directional ones and then some rocking and reaching. You'll notice next we've got some functional component tasks and examples there of things like pulling keys out of a pocket or using a cell phone. And we'll get more into how these are always going to be patient selected so that they're driving into that meaningful engagement. On the right-hand side of the screen, then you'll see those hierarchy exercises that we're going to get more into, more of those complex functional tasks. Big walking, different distances and times is always going to be part of every treatment session. The homework every day is going to include all of their exercises, their functional component task, and their big walking, all 30 days of the month, even the days they're not with you. And then their carryover exercise, we'll get into a little bit more how that's like trying to get practice in their everyday life just outside of the clinic. So you'll notice how these on the left-hand side, these core amplitude rescaling exercises help to translate that amplitude into these functional, salient, patient-driven, individualized goals. So here's a video example of the LSVT big exercises. And as you're watching them, I want you to think about how this would maybe relate to someone's functional goal, something that they want to be able to do in their life.
Our next exercise is the step backwards and reach. You want to be sure to start with your big posture, and you're going to have big hands, and then we're going to do a nice big step back, big arm movements, and then come back and finish big.
swings. There you go. Nice job, Bob. Reach, 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 reach. One more and big finish. Ready? Big twist. Good, good, good. You can actually have this one way out here, this one out here. Nice. And big finish. One more, just like that. Big twist. There you go. Nice job, Bob. And back. You got better with each one.
So you can see when you're watching those, you think about that backward step, that could link to a lot of things, getting out of the path of a door, path of an elevator, oncoming, traffic, walking toward you. So you always want to think when you're working with these individuals of how to link the exercises to function. So, the why, they're getting that balance and weight shift and reciprocal arm swing. They're going to get balance and weight shift when they're reaching up high. They're getting that balance for those backward protective responses. They're getting some rotation for dressing and walking and driving. I mean, as he's reaching up here on the bookshelf, it looks a lot like that rock and reach exercise. Also, that initiation of stepping, when we get into some of the standing and stepping exercises, stepping over the shower, onto the curb, or up onto the train or bus. That sideways stepping, we use a lot of times in theaters to go down the aisle and step over people or their handbags. We're maneuvering in the kitchen or in the bathroom. Even making the bed, you have to work on sidestepping. Stepping back, there's so many times that people use that, moving out of the way or even backing up to sit down in a chair. So there's always a link and a function to the why we're doing these exercises. So we essentially want all of those exercises and how they link to function. But now this is where we get into the habit training part. We want that personalized, purposeful practice. So salience matters so much. This is one of the principles of neuroplasticity. And this is practicing these tasks that are rewarding, right? That they're building success, they're emotionally salient, because it really helps to activate that basal ganglia circuitry. So you want to incorporate tasks that are really meaningful to that person. That's going to help enhance their motivation. A gentleman I had early on, I remember he was rather young with Parkinson's, and he just wanted to be able to cut his steak. So cutting food was one of his functional component tasks. And when he was able to cut his steak, that first Friday night, first week of the program, when he went out to dinner with his wife, he came in the next week with a list of all these things he wanted to work on because he was really motivated then. He saw he could do more. You want to link their program, the entire thing, to their functional goals. So when you're working with those exercises, helping them understand how these are going to improve their, being able to play with their grandchildren or go and hike with people or maybe continue their work tasks. You want to always practice doing things that they enjoy too. So incorporate different hobbies. I've worked on cooking and baking and knitting and crocheting. I learned how to play paddle tennis just to really help them achieve that self-realization and improve their participation. I had to go along for the ride. And ultimately, we're always utilizing this task-oriented, client-centered treatment in every single session. And this is also going to help to address the depression and apathy. There's a study I didn't highlight about LSVT BIG where they actually showed improvements in the geriatric depression scale. And what makes you feel more depressed than when you can't do the things that you want or need to do? And so this can really help improve mood as well. And it's important to note not just salience, but that specificity matters too. You want to train specifically to those deficits of hypokinesia and bradykinesia, and you want to include that task performance. So cycling is not necessarily going to carry over to bed mobility, right? Any more than the long arc quad here carries over to getting up and out of a chair. If you want to practice getting out of a chair, practice getting up from a chair, and if possible, from that chair, and at that time of day, and with that lighting as much as you can. And we know that repetition is really key to learning too. And of course, across the program, you'll notice in the box there, they're getting all of these repetitions per day and per month. look at that, in the thousands, in the hundreds per day, in the thousands per month. And so this constant, repetitive, high effort where they're overlearning these tasks is going to help so much. And it's throughout all of their exercises and their functional components. Also, their hierarchy tasks are going to be patient-driven as well. But across the program, we're looking at how do we vary it to meet the different challenges they may face in daily life. We want to progress it and keep it high effort across the entire program. So these functional component tasks I keep going on about, you want to overlearn these common, simple, everyday functional movements like a sit to stand. We want to get that amplitude into their daily life. We want it to become a constant reminder to use these bigger movements outside of therapy all the time. And this, like I said, with my gentleman with the steak, really encourages that compliance and carryover. They essentially act like a calibration hook. They start to notice, wow, if I move big, this is what happens. And to do this, you've got to discuss their real life. You want to really understand, what do they enjoy doing in the kitchen, in the garden? What ADLs are they having trouble with? How do they shop? Do they go to the store? Is it online shopping? Because ultimately, whatever they want to participate in, we want to remove the barriers and help support that participation. So now looking down, we went through the exercises here on the left side of the screen, and get a little bit more into these functional component tasks and these hierarchy tasks here. So here's some examples of some functional component tasks. And I want to see if you can think of what this first one here, what this lady's trying to do. You can type it in the chat if you want to, like, what do you think this is simulating practice of?
Hand and pull. Big left hand and pull. Go for it. Yep. Go. Big left hand. Left hand. Left hand. Yes! Left hand. Good. And stop. Good.
So what do you think? Gotten all kinds of answers in the past. So this lady worked at a drugstore, right, where she was a manager, and she needed to be able to open up that big gate when the trucks would come up. And her left side was her affected side. So she was having a lot of trouble. It was taking her much longer because her movements were so much slower in pulling on that chain or rope to pull it down. So you notice how even her cueing was specific. Big left hand, big left. So really cueing and driving that amplitude specifically where you need it. All right, now that you know what she does, what do you think this is maybe simulating?
With your left hand, okay? Pull, 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 pull. Now with these cards, every time you pull, I want you to say out loud that word.
Okay, what it is on the card.
What it is on the card.
All right.
Ready?
Yep.
And go.
Etching,
Big.
alternative, memories.
Keep it going.
Memories, alternative,
Pull.
memories,
Pull.
alternative,
Louder.
memories,
Bigger.
memories,
Go for it.
alternative,
Pull it.
valuables,
Pull it.
etchings.
So she had to count money, right? And she was having difficulty. That was taking her longer, kind of moving the bills. And if you think about the task of counting money, it's not just a manipulation, right? There's also, you've got to be cognitively looking at it and reading what denomination the bill is. So those were just some cards in our clinic laying around that she used. We didn't have piles of cash, but we could use those cards to practice those same tasks.
Handed with your left.
So what about the fine motor task? We know that even these get way too small for people with Parkinson's. Doing little buttons, brushing their teeth, stirring, those become so problematic over time. So ultimately, you want to observe the patient's performance and compare that to normal. We always get questions like, well, how are they going to put mascara on big? But it's really about what is too small. Maybe it's how they're holding the wand in the mascara. You're going to observe their performance, and then you're going to model and shape that movement, showing them what needs to be bigger, driving that effort. You notice how she was using so much energy, big left hand, until that patient is scaled up to normal movement. Another little trick with the hands is sometimes we don't really know why, but some flicks beforehand will really wake the hand up and make those fine motor tasks a little easier. So here's an example of how you can approach training with buttoning. Just a couple of ideas.
Good, and I want you to kind of notice as you're watching Bob do his buttons, kind of it's a very slow, small kind of movement that he's using to try and get those buttons through the buttonhole.
Yes, we do struggle.
And this can be a very frustrating thing for a lot of people, Bob. You're not alone in that. Does the top button tend to be one of the hardest ones for you?
Yes.
Okay, okay. Good, you got it though. All right. Do that.
Well,
Let's
let's
do
do
it.
that.
Ready? 1, 2, 3. Go again.
Wow.
Really push it in hard. Nice.
About a third of the time.
You're right, you're right. Good job. Now go back in and close it like you're angry with it. Really push it in strong. Nice. How fast was that?
Even quicker.
Even quicker. You're right.
I haven't done a button that quick and I don't know how long.
Good, good.
So there's a couple of ways to approach that button, right? Doing those flicks beforehand, showing him to get angry, like really whatever drives the amplitude. But what I love was the change in his face. You saw how he looked really frustrated when he was first doing it, looked a little uncomfortable, and then he just lit up there at the end. All right, so that was a functional component, right? Kind of that simple motoric movement, just putting that button through the hook. When we're talking about a hierarchy task, these are going to be 1 to 3 patient-specific goals that you're going to discover through discussion, observation, this functional task recording form. So there's not more to come, unfortunately. We could show you what it looks like another time. And these are complex, multi-step functional activities. They're going to be a part of every session, and across the time of the program, you're going to build them. So it's going to be something like a car transfer that maybe you're just working on certain parts of it each week. So here's some example of different subtasks. So say that maybe the hierarchy task is preparing a meal. We have to look at maybe it's retrieving the ingredients, gathering the tools, preparing the food, stirring to put a pot in the oven, and eventually serving the food. So the breakdown or the problems with this for an individual could really happen anywhere in any of these subtasks. So we'll take a look here at an example of a hierarchy video of a jacket. So putting on a jacket. And you'll notice how what Jenny really tries to do is find what is really the most problematic part of the task first and really kind of tackle that with her cueing.
Okay, so we're next going to look at putting on his jacket, which has been a functional task that Bob reported has become a challenge for him. Very similar to, getting your shirt on or shirt off, jacket on or off. A lot of those dressing pieces are a real challenge. So we're going to kind of go through the teaching techniques of how we might model, shape, drive, calibrate an actual functional task. So to start with, Bob, would you just please put your jacket on for me like you usually do? Very nice. So what you may have noticed is increased time, predominantly the first place we saw that is in the reach of trying to get the second arm to the jacket, and then also taking it from that point to being able to get it up over his shoulders with the collar in the right place. And that is very commonly what we see, the main sticking points that people get stuck on with that jacket. Would you say that's the sticking points that you notice too?
Those are them.
All right, yes, yes. So go ahead and take your jacket off for me now. And the piece there is once you get it off the shoulders, getting it all the way down off your arms, right?
That's right.
Where the problem comes into place. Okay. So what we're going to do is what you've been learning with us today is that we have to increase left arm into the sleeve of your jacket.
Okay.
Okay? Oh, and we missed. Try it one more time. Very good. Okay? Very good.
Continue.
Now go ahead and take it off again for me.
Okay.
So that was better. Now what we're going to do is we're going to add on to that this time. Okay? So you're going to get that strong punch into the sleeve, get it way up there, and then with your right arm, a strong punch back into that sleeve.
Okay.
Okay? Go for it. Good. Reach strong, reach big. Fantastic. Now a big pull up on the coat. Very nice. Very nice. Okay?
Wow.
That worked a little bit better?
A lot better.
A lot better. Yeah, yeah. Okay, so I want you to do it just like that again. Okay, so let's take the jacket off, and this time, getting the jacket off, how do you think you might get the jacket off?
I'm going to emphasize my separation here at the
Yeah.
belt level.
Up.
Just big.
Big
push
movement
off.
taking it off, exactly. All right, go ahead and give it a try. Yep, really pull it down. Big pull in the sleeve. Good. Big pull on that
In
sleeve.
fact, I pulled on so hard I couldn't get to the sleeve. It was covered up by the rest of the jacket.
There you go.
Okay.
Good. Good. Okay.
Super.
Okay. So we're going to go through that and do it again. Okay. With the big effort, pushing in with each arm movement and with the pulling up of the coat. We're going to put it all together.
Okay.
All right.
Here
Ready?
we go.
Big reach. Good. Big punch back. Big pull up. Good. One more big pull up.
Half the time.
Half the time. You
What am
got
I
it.
going to use for an excuse to be late now?
It'll eliminate that excuse, won't it? Won't
Yes,
it?
it will.
Okay, but that's the amount of effort that I want you to use every time you put your arm into the jacket, okay?
Yes.
And I want you to try it every time, whether it's your jacket, whether it's your shirt, or anything that you're using like that. You need to have increased effort as you're pushing through, okay?
Got it.
Let's get it off one more time with nice big effort. Good. Big pull out.
Big pull out. And
Yep.
just cover it up. And
Good.
Good and good.
Very nice.
I am now the master of my coat.
You are, and that's exactly how I want you to get your coat on and off every single time you do it.
Will do.
Okay?
Excellent. So that was such a great example of, you notice how she really was breaking that down, at first into kind of those different subtasks. In the beginning, you're going to remove complexity and environmental challenges and identify where that problem is. Where does behavior break down and why? Across the weeks, though, as you progress this, you notice you're going to be doing block practice week 1, working into sequential week 2. By week 3, you're getting into longer sequences, and hopefully by week 4, doing the entire sequence and adding in some random practice. And then I want you to notice too that your feedback changes. In the beginning, like you saw Jenny, she was given a lot of feedback. There was a lot of education, a lot of information she was giving, and that's going to go down because hopefully by week 4, they know what that big reach into the sleeve feels like. So they're going to self-monitor their own performance more. So how do you do that? How do you get them to carry over the use of those bigger movements to their everyday life, even to things that maybe you haven't trained or different situations that you didn't think about? Well, we do that through carryover assignments. And so these are daily assignments that you mandate for them to use their bigger movements in real life situations outside of that therapy session. And the purpose of these is to essentially convince the patient that these bigger movements are within normal limits. They don't look weird to people. It's not going to, cause any unnecessary attention, but what it will do is positively impact their daily functional movement. So here's an example of a carryover assignment. You might say, okay, what are you going to do tonight? And the client says, I'm going to go home and I'm going to have dinner with my family tonight. All right, so tonight when you eat dinner with your family, I want you to use your big movements when you're cutting your food. Cut big enough that your family notices because they see how easy it is, not because it's ridiculous. Tomorrow, tell me what your family thought of your big cutting, because we always want to check in the next day and get that feedback. Because ultimately, as I mentioned earlier, we're trying to calibrate that performance. And so this is what Jenny was doing. She was really teaching Bob how to recognize and accept the relationship between his big movements and that normal motor output. That's the effort you're going to have to use every time you put your jacket on and try to get your arm into the sleeve of that jacket. So LSVT BIG really addresses that mismatch between their perception of their movement and how others perceive it. That is that calibration training. And so I remember early on, there was a woman coming into our clinic and she was working with a physical therapist, and she was very Brady and hypokinetic, tiny little shuffling steps. And I remember the therapist said, I just want you to go crazy big. Give me your big walk down the hallway. And I look up and the woman just looks like she was walking, even still a little smaller than normal. And she's like, I can't walk like this outside. People will think something's really wrong with me. So it felt so off to her. That sensory mismatch is really huge. And that path to calibration involves a lot of effort on our part, because we have to essentially convince the patient that these bigger movements are within normal limits and they're going to positively impact their function. But we don't want to just convince them. We want them to become comfortable with these bigger movements and this greater effort when they see how it helps them. And also they realize that it doesn't look funny to other people. And we're going to help them recognize the need for that increased bigness to do everything that they need to do in their day-to-day life. So the process of calibration is going to take all 16 visits to achieve. And that repetition is really the key. They don't practice it till they get it right. They practice it till they can't get it wrong. We're going to have them do it again. So some takeaway messages here as we're wrapping up. Slagle's original concept of habit training, I hope that I drew the line well enough, has evolved into that modern concept of task-oriented training and also client-centered care. And when we think about this, how complex the motor and non-motor symptoms associated with Parkinson's disease are and how they impact function, this really requires our holistic lens, I think, as occupational therapists to help people with Parkinson's really achieve what they need to achieve and live their life to its fullest. You can utilize that patient-centered approach to assessment by utilizing function-based outcomes to inform these areas of habit training based on what the client's interests are to improve their independence and quality of life. And I think LSVT BIG provides such a great evidence-based protocol to facilitate this habit training and really help guide that patient-centered care. So I think that it's an excellent tool for you to use at all stages of your practice. So there's some references. You can go onto our website if you're wanting to find some of the research articles that were referenced in this presentation. There's a lot of opportunities to learn more with our blog resources, some web resources, and social media. If you were thinking about getting trained, we have an online training and certification program that you can watch pre-recorded modules. It's 14.5 hours long. You'll notice there's a lot of videos and video-led practice. Or you can join us and do the virtual live training and certification, where there's a mix of pre-recorded and virtual interactive sessions. We have a great practice session with people with Parkinson's, and you can always find our schedule of upcoming live courses at the on the website. All right, so with that, that's about the survey. We'll see if there's any questions if you have any. So thank you very much for your time and attention. I'll check the chat here, but thank you all so much. All right. Whoops. So any questions here at all? Maybe not. Did we get anything in the Q&A?
No, I didn't see any questions come in, Julia. So we are at the end of our hour for the webinar. So if you do have any questions, please feel free to put them in the chat. We can stay for a few more minutes and answer those. If you've heard all the wonderful information and you're ready to go on with your evening, you are free to leave us. Just a reminder to take that survey after you're done to be able to get your certificate after the webinar. So thank you, everyone. We've seen lots of thank yous come in. Thank you for sharing. But yeah, have a great night, everyone.
Thanks, Jenny.
Good. Oh, we did get one question that popped in, Julia, just as I said that. I was just wondering if the big flicks can be useful for clients with tremors and hyperkinetic movements.
Absolutely. I think that's a great question. The flicks can be used, especially if people have some tremor. I think sometimes it can offset some of that resting tremor because you get that activation through the hands. So yeah, I think with all of these things, think of them as tools and you can try it. And, it might help someone's tremor. It might, not help another person's, but it's a tool to have in your toolkit. Great question. Excellent. All right. Thank you all.
I think that was it. So thank you everyone for joining us. We look forward to seeing you in a future webinar. Have a great night.
Thanks, Jenny.
Thank you.
Bye.